My name is again Dr. Jennifer McVige. I'm from Dent Neurologic Institute in Buffalo, New York. I am a board certified pediatric neurologist. I'm also board certified in headache medicine, as well as neuroimaging, and I'm the director of the Concussion Center here at Dent Neurologic Institute. So we're about a minute in, so I'm just going to get started and speaking a little bit about pediatric migraine and pediatric and adolescent headache. We're going to talk about headache first, and then we'll get into what constitutes migraine, as there's some confusion sometimes with individuals understanding what a migraine is. So first, pediatric headache, or just headache in general. Some of the issues that we have is that many people will come and say, is this a migraine? Is it not a migraine? More than over 90 to 95% of the time, people will come in and say that they feel that they have sinus or sinus headache. Sinus headache is often misdiagnosed, and a lot of the kids will come in and have already had antibiotics. If you have a sinus headache, typically you will have either a low-grade fever, nasal discharge. You can have post-nasal discharge from the throat. You feel achy, you feel sick. You also will have pain up in here. Little kids do not have frontal sinuses that develop until they're about 15 or 16 years old. So I constantly get families coming in and saying, you know, this child has a migraine headache, or I'm sorry, a sinus headache because it's right here. That's not the case because they don't even have frontal sinuses at that point in time on neuroimaging. So it's unlikely that that's a sinus headache, and that's more consistent with migraine. Some things to be concerned about if your child says that they have headache. And we call them the red flags and reasons why we might want to image someone to find out, is this a migraine or is it something else? If it's an abrupt onset of a very severe headache out of the blue, something that wakes somebody up in the middle of the night, it doesn't go away once they go to sleep. If there's radical change in somebody's established headache syndrome, so if they've have headaches, you know, once or two times a month, and then all of a sudden now they're having severe migraine headaches on a daily basis, that's a big change. A facial pain that is very focal could be a tooth abscess, so something in here. If there is any kind of stiffness or pain in the neck and the patient cannot tilt their neck forward, then we would be very concerned that there's more of an infection going on or something else going on. If someone has a seizure, it's a headache, that's concerning. If they have swelling behind the eye, it's concerning, but that would be a doctor to decide. If there's profuse vomiting, vomiting is actually very common with little kids who have migraine, but usually they'll feel better afterwards. But if they continue to vomit and they're not feeling better, that's very concerning. If they have altered mental status, they're not really behaving appropriately. If there's been a head injury associated with it, and if they're not walking correctly, you know, ambulating, they're kind of dizzy and unsteady. If there's an incredible increase in the head pain with coughing, bending over, exertion, that's a little bit concerning. Also, if someone says they have head pain right back here, there's something called Chiari malformation, where the base of the cerebellum in the back of the brain can sit a little lower in some people, and this can be aggravated by certain activities. And that can cause a very particular type of headache, which is a posterior occipital headache back here. And that's not necessarily migraine, that's consistent with that disorder. So those types of issues would encourage us to do some sort of imaging in someone to see if they are okay. Also, if someone has a very high fever, if they're immunocompromised, if they have any kind of hardware in their head like a shunt, or if they have multiple dark spots on their body, like cafe away spots they're called, then we'd be a little more concerned. So if you have lots of, as my daughter calls them, sprinkles, but they're larger and they're dark and they're numerous, then you might want to talk to your doctor and have your skin looked at. So let's move on and talk about the neuroimaging aspect of things. I have a lot of patients that will come in and be very disappointed that the ER or the primary doctor did not do a CT scan. And my advice is, you know, a CT scan often is, well, a CT scan involves radiation. So a CT scan is reserved for individuals that have either an intracranial bleed or some sort of a fracture. It's very good at seeing those things, but it's not very good at seeing very finite, small changes within the brain. So going to the ER and requesting a CAT scan is probably not in your best interest unless this is a really bad trauma, or you think there's a bleed or a stroke or something like that. An MRI tells you a lot more about what's going on with the person, whether they're an adult or a child. We can image children way down to low ages. Here at Dent, we have very fast scans up to 15 minutes at a time, and the kids do really well watching a video. You'd be surprised the kids sometimes do much better than the adults in the MRI scanner. So we wouldn't image everyone that has a headache, but they would be just for the concerning things that we just talked about a few minutes ago. And you should talk to your primary doctor about those issues if that occurs, if those concerns occur. Also, let's talk a little bit about what is a migraine, what differentiates a migraine. We'll talk about that first. So there's different types of headache. There's migraine with and without aura. Even pediatric kids, patients will have similar to adult presentation with migraine with and without aura, but there's a couple little changes. The diagnostic criteria for the international criteria for diagnosis of headache for migraine without aura in a child is that they have to have a headache that lasts at least 1 to 72 hours. That's if it's untreated. The headaches have to have at least 2 of the following characteristics. So it says unilateral, but I'm going to tell you that the majority of pediatric patients have bilateral pain, meaning both sides, and it's usually right in the forehead. Adults will say the head pain is here. Kids will say it's right here. A pulsating quality, so like throbbing. Also, it has to have a moderate to severe pain intensity. It's not just like a dull headache. It's aggravated by physical activity, and you have to have at least one of the following during the headache, either nausea and or vomiting. You don't have to vomit, or sonophotophobia, meaning light sensitivity and or sound sensitivity. So oftentimes in a kid, you don't really elicit that information very easily. So by knowing that, you know, when they don't feel good, they immediately retreat to their room, and they are, you know, they don't want to see anybody. They want to stay in a dark space. That is a sign that that there is an issue with the light sensitivity and sound sensitivity. And I just want to take a second to thank Catherine Archibald for the thumbs up, and Cynthia Salazar all the way from Costa Rica. Thank you so much for watching. We appreciate that. Okay, let's talk about what happens with a headache. And in peds, as in adults, there's different stages. So there's a prodrome, which means up to 24 hours ahead of time, kids can, or adults can feel like they're nauseous, they're very hungry or not hungry, like they just feel uncomfortable. They can feel achy, they can have a little bit of neck pain, they can be confused, not make much sense, and light and sound will hurt their eyes even before the headache can start. Then you get the headache, and then you have postdrome, and it's almost like you feel, and this can last for a long time, actually many hours to even a day. And this can make you feel almost, for an adult, like it's a hangover. You know, you just feel kind of wonky, and you just don't feel like yourself, and you're exhausted, and you're not processing information correctly. So this happens to our little kids too. So be mindful of that. That's very hard for them. Imagine them sitting through school and having to process information that way. Usually kids' headaches will last from up to 20 minutes to 72 hours, but most are about 2 to 3 hours. Adults have much longer headaches usually. We'll talk a little bit now about the fact that kids can actually have a little bit of a low-grade fever with this. This will throw some parents off too. They'll say, my kid had a fever and it's awful. Well, that actually can happen, like a 99.9. So it doesn't necessarily mean they have a raging infection, but then when the headache's over, it goes away. They can have some blurring of their vision, and it can be triggered by certain foods or things that they're eating. So some of the big things that we talk about avoiding for kids and for adults is nitrates, which are luncheon meat, pepperoni, salami, bacon, hot dogs, smoked meat, cured meats. I try to tell people use the organic luncheon meat if you're going to do that, or hot dogs. And then also MSG, monosodium glutamate, the lining of soup cans, bouillon cubes, salad dressings, ramen noodles. Those are big ones. I had one young lady who I just told her to stop eating ramen noodles and her headache magically went away. Go figure. They have a lot of sodium in them and MSG. Also, fake cheeses, Doritos, fishy crackers, which a lot of people give their kids. Try to get the organic versions of that. And those are okay. Caffeine, cheese, chocolate, red dyes, diet products with saccharin. Stay away from those things. Also, in young teenagers, what I see a lot is skipping breakfast. So make sure that they're having a good morning meal. Also, trying to get a good night's sleep, and sleeping enough is very important for children, and drinking enough water, especially in the summer months, hydrating enough. And so those would be things to stay away from. Kids as well as adults can be triggered by perfumes as well as odors and the fluorescent lights and weather. So as far as migraine with aura, let's talk about that for a second. So the difference with migraine without aura and compared to with aura, only 18% of children are going to have a migraine with aura, and 13 will have it with and without aura. 5% can experience only aura but have no headache at all. So you can have just the vision symptoms but without any headache at all. So diagnostic criteria for aura is it's a fully reversible syndrome of visual changes, so flickering lights, zigzaggy lines, black spots, bright spots, and it goes away completely. It doesn't stay. If it stays, that's very concerning, and you might want to think about neuroimaging for that patient. You can have speech changes, almost like stroke-like symptoms, but it's not a stroke. You can have numbness and tingling. You can have loss of one side of vision. Usually what happens is this will be 5 to 20 minutes before the onset of the headache. It can be up to an hour before the headache. If greater than that, then you want to worry about something else going on. Sometimes kids can have something that's interesting called Alice in Wonderland syndrome, where they perceive things as being incredibly big and incredibly small. So it's almost like, you know, the Mad Hatter with a big head and a tiny, tiny body. Kids will say that things look very distorted, and that actually is called Alice in Wonderland syndrome. We just a few statistics for you too, because I know there's always that kind of thought that, well, kids don't get migraines, but they do. So migraine usually goes underdiagnosed in kids or undiagnosed in kids because, again, people think it's something else. Oftentimes, we don't think that the kids can't verbalize things correctly, so it's difficult for us to understand what's going on with them. So, you know, really talking to them, having them draw it, having them talk about it a little bit more with you. Specifically, I always ask questions like, what does it feel like? Is it like a bell's going off in your head, or does it feel like it's stabbing, or does it feel like it's like your heart beating in your head? And giving them kind of visual cues is really helpful. So 10% of school-age kids are going to suffer from a migraine, and half of all migraine sufferers are going to have their first attack before age 12. A lot of times if you talk to an adult migraineur, guess what? They'll say, you know, now that I look back, now that I know what a migraine is, I realized I was having migraines down to like 5 years old, 7 years old, and it's really sad because they'll say, well, I wish I would have known then what I know now, because I would be able to treat myself better, and I probably would have felt better when I was younger. Also, colic has also recently been associated with predicting if someone's going to have migraine when they get older, and we know that torticollis in a baby, where their head is tilted to one side when they're born, can also be associated with onset of migraines later. Children who suffer from absences from school children with migraine suffer from absences from school twice as often as children without migraine. And in childhood, boys suffer from migraines more often than girls, or even equally to girls at times. But then as adolescence approaches, it's actually girls that suffer more, and we believe that might be related to hormonal changes. So you'll see that kind of change. Usually a child has one parent with a migraine. A child who has one parent with migraine has a 50% chance of inheriting migraine disorder. and if both parents have migraine, this rises to 75% chance. So if you have migraines yourself, it would be important for you to ask your child questions about this. In addition, about 1 out of every 20 kids, or 8 million children in the United States, will get migraines. This is a really concerning issue for children. It's funny, I had one child that I took care of who did this whole essay and did this whole presentation to school about migraine days and days off and how it was difficult for her. And at first it wasn't really well received with the school until we kind of got behind her and helped her. And then it turned into this big presentation. She got this huge award. I think because it's a silent illness, people don't really see how bad you feel. You know, they look at you and say, well, you look fine, you know, you got dressed and showered and you got up for the day, but am I really participating 100% in that day? That's the big question. And think about your 8-year-old trying to get through a day of school and learn math. That's really kind of concerning. Kids with migraines are 2 times more likely to have absences from school compared to other kids. 75% of headaches in kids referred to neuro actually are diagnosed as a migraine headache. So this is a really concerning topic. Some other types of headaches that I'll just go over, I only have a few minutes left, and I'll go over some questions that sometimes people have. There's different types of headaches that don't involve the head as well. There's cyclic vomiting, so some kids will have just episodic vomiting over and over again, and you have to have at least 5 of these attacks to fulfill this diagnosis. And these are episodic attacks where the patient will have intense nausea and vomiting for up to an hour to 5 days. The vomiting attacks occur at least 4 times per hour for at least an hour, so it has to be very repetitive. And you can be symptom-free between attacks. It's not like an illness that you have, but this is called cyclic vomiting. IV fluids can be helpful. There's increased risk in girls. Usually there's some of family history. Sometimes it's been associated with increased anxiety and issues with anxiety. It can be a precursor to individuals who are going to grow up and have migraines. It usually is in preschool kids, but it can happen at any age, even in adults. And typically, the antiemetics that we have aren't as helpful, but oftentimes some of the headache medications that we use, even the tricyclic antidepressants, can be helpful for that one. Abdominal migraines is another thing that kids come in and are diagnosed with. This is at least 5 attacks of this, so you have to have at least 5 of them. It's abdominal pain lasting 1 to 72 hours, and the pain is usually in the center of the belly. It's like a dull soreness. It can be moderate to severe intensity. It's not really a mild, uncomfortable pain. It hurts. And it has nothing to do with another disorder, like some sort of another GI or disorder that has to be ruled out. It's usually equal in boys and girls. Obviously, like I said, you rule out organic causes such as constipation or a GI illness. 70% of these kids are going to go on and develop migraines, and usually it'll last for about 12 hours and then go away. Despite all this belly pain, these kids will still have normal growth, normal weight, normal development. They're not restricting their diet. And as I said, one of the other things is this paroxysmal torticollis of infancy. We found that this is rare, but a lot of kids will have a tightening of the neck in here, and we found that a lot of times this is a precursor to migraine type headaches later in life. Usually it's under 8 months of age you'll end up seeing that. It's more often in girls. You have to exclude other illnesses, but that is something to be concerned about. And the last thing before I take some questions, if anybody has some questions, is tension type headache. Kids can get tension type headaches too, and the issue with tension type headaches is that they get stressed just like we do. And I know people will say, what do they have to worry about? Well, nowadays with school, I mean, these kids have such intense pressure to perform well in school, as well as do well with their athletic activities and be involved in all sorts of extracurricular activities in order to do things that they need to do later in life. It's just, I think it's way more pressure. Maybe I'm dating myself as being old, but way more pressure than when I was younger. Usually tension type headaches dates back to childhood, so even adults that have tension type headaches, you can tell that they are just these people that will pull into themselves. You know that the trapezius muscles are very tight, the paraspinous muscles are very tight. Sometimes they'll have temporomandibular joint tightness, they'll grind or clench their teeth. or it pops when they open and close their jaw, and that can be associated with a tension headache too, but that's that can be TMJ, or temporomandibular joint dysfunction as well. Most of the time, these people don't have the light and sound sensitivity as much, but it's more of like a dull, achy pain in the neck and shoulders. This is a different type of treatment, so it's not as much migraine, but I wanted to put it out there to make people aware. One of the things that we're seeing now with the children is the texting. So talking to kids about their screen time and making sure their head isn't down all the time, and they're not texting and they're not typing for work, school, and they're not doing their homework in their bed with their shoulders hunched over. I talk to the kids in the room and I say it's like a turtle pose. So you look like a turtle and your shoulders are hunched over. You can't do it very much in this, but your neck is hunched out or pushed out and your shoulders are hunched over. And it's really hard to get your chin back with that type of pose. So making sure that we have good relaxation in the upper shoulders and the neck. I teach kids relaxation techniques, calming techniques. A lot of the studies have shown that oftentimes relaxation techniques and even placebo in some of the studies worked equally as well as some of the medications, but there's definitely a subgroup of population of kids that really need to have appropriate medication therapy, appropriate referral to either first their primary care provider, and then if the headaches are not getting better, then a neurologist who specializes in headache medicine or treats pediatric headache. That would be ideal if you have that in your area. There is this huge differential, like I was telling you, of different types of headaches. So to weed that out is very important, but also to understand how to guide people through the treatment phase if there is medication that is needed. I'm going to stop right there and see if anybody has any questions so far. Thank you, Alice, for joining us. I'm going to scroll down. Maybe I'm not down far enough. Okay. Can I comment about abdominal migraine? I think I did okay. I have Laura Ann on. Reply back to me if I didn't answer your questions about abdominal migraine, but I know that they had given you a good article to help with that as well. What is the earliest diagnosis that migraine can be given in a child? Thank you, Barbara Weston, for your question. Down to 18 months of age, sometimes we've seen this. Like I said, we believe that torticollis and colic is actually a precursor, and that has been proven in some studies. So interestingly, if you want to take that as a precursor, take that as face value. But you can diagnose. I've seen patients down to 2 years of age. If a kid comes in at 2 or 3 years age and they're able to verbalize and they say, I have a headache right here, you really need to be cautious. And usually the younger kids I'm imaging a lot more freely because I get a little concerned if a child that young can tell me exactly where their headache is and how bad it is. There's something that you need to worry about. Now, if you find nothing and they do have this light sensitivity and they're vomiting, then usually they'll have a very strong family history. Somebody has migraine, and then we end up treating them with treatments. I like to do vitamin therapy. I like to do behavioral therapy first. I like to work on the neck and the shoulders, relaxation techniques, and get rid of the triggers, the food triggers in your life, sleeping, water, those kinds of things first. Then you can resort to medicinal therapy, obviously, if things are not working. And thank you, Leopoldo, for joining us. We had a question about dizziness associated with migraine in girls with hormonal migraines, 11 to 13 years old, with Ruth Fitzsimmons. The dizziness is actually sometimes associated to the upper cervical stuff. So if ever there's dizziness associated with migraine, make sure that you, have ruled out the upper cervical tightness, that the muscles are relaxed and stretched. Maybe you can do physical therapy. I'm very fortunate in Buffalo to have two very amazing non-traditional chiropractors, so there's not a lot of popping and cracking, especially in little kids. There's like a deep tissue release. We have a craniosacral therapist here who's wonderful. So I think that those would be things that you would look at first, because that myofascial spasm is so prevalent in so many of us. We all have horrible posture. We were not meant to sit like this all day, but we do as human beings now. There are vertiginous migraines where people feel very dizzy, almost like the room is spinning or they're on a boat. That's a little bit different from regular migraines, and that's a different diagnostic criteria. And sometimes you might want to make sure that the vasculature is okay in the back of the head, and that, again, the jaw and the neck are loose. But that's a totally different topic. But yes, the dizziness, hormonal changes in girls, and thank you, Ruth, for that question too. That's some of the reason why we think that young ladies have a higher incidence of the headaches. Is that when we have those big hormonal changes. So the interesting thing about the dizziness with hormonal changes and migraines, what happens is that estrogen increases when we start to get our period. It like rises and then abruptly drops. And so that can trigger headache, but it also causes the vasculature to dilate. And when the vasculature dilates, like the venous system dilates, oftentimes we can't pump blood as fast, and so sometimes we have a rapid heart rate. This can provoke anxiety, dizziness if you're standing for long periods of time. Some kids will have syncope or passing out, very common in that age range due to these abrupt changes. But headache is also very common with it too, so this may play a part in that whole vasculature, heart rate, and that whole process. Leah Porter asked, do foods that you eat affect your migraine? Absolutely. We went through, especially processed foods. Get the processed foods out of your diet. They are not good for anybody, and they really do have an effect, especially with young children. The tendency, eating fast food, eating chips, eating fake cheeses, eating anything that's not the color that it's supposed to be is probably not a good idea. Can massage help with eliminate pediatric migraines? Massage can really help with that myofascial tension. It can help with relaxation. A lot of pediatric migraine I see is stress and anxiety, and talking to kids about coping with your moods and your emotion and communicating is so big. If they can learn to use their words and communicate appropriately, have good relaxation techniques, have proper bedtime routines, eat properly, take care of their body will only do what you want it to do if you're good to it. So you have to be good to your body. So yes, massage can be incredibly effective. Jill Suman, 15-year-old daughter suffers from migraines. How safe are the migraine medications like Emerge? Do you recommend something else? 15 years old is wonderful. There are FDA-approved medications down to 6 and 12 years old. So there are many of the triptans that are FDA-approved down to 12 years of age, between 12 and 18 years of age. And there's a few that are even FDA-approved down to 6 to 12 years of age. We are in the process of doing actually a study here at Dent for another migraine medication that is a triptan for 6 to 12 years of age. There are preventative medications that are used. Not everything is FDA approved, and the challenge is that historically there haven't been a lot of pediatric drug studies. Unfortunately, I think because everybody had the feeling, well, we'll just half the dose and little people will be fine. That's not true. Little people don't get half the dose and they're not fine. Kids are not little adults. They have different metabolism, different ways to deal with medications. But there is a subpopulation of individuals that will respond. Obviously, if someone is repetitively using their rescue medications, their triptans, their NSAIDs, I try to get patients off a lot of over-counter medications like Tylenol, Motrin, Excedrin. Excedrin is just not the greatest. If you overuse those more than 3 times a week, this can lead to problems with your GI health, problems with your kidneys, problems with your liver, and sometimes in severe cases lead to medication overuse if it's going on for several months. So we try to keep people away from that. I do think the triptans are safe. I use them all the time in my patients. I often try to use the ones that have lower side effect profile. Emerge is one of those. And it is perfectly fine as long as it's making the headache go away. You want to take your rescue medication within the first 1 to 2 hours of the onset of a headache. You don't want to wait longer, or else the headache can persist for several days. Oftentimes, if that person is overusing their rescue medications, then we need to put them on a prophylaxis medication, which means a daily medication so that they don't get headaches. The goal in life, people, is that we just don't want headaches. We don't want to chase our tail overusing rescue medications. So there's a bunch of new medications that are on the market too that can be helpful, that we're doing some research on longitudinally for those very severe sufferers out there, and hopefully within the next year we'll have some good data on that as well. But if you are concerned, if you need to talk to your pediatrician. If you're still concerned, find a pediatric neurologist who specializes in headache. We are out there. I know there's not a ton of us, but we're here and we're happy to help. And it is not a fun thing to suffer from migraines. I'm a migraine sufferer myself, which is why I'm very adamant about posting and doing these things and talking to people about it. So just think of your child going through that. So are there any more questions that anybody has? I think I'm scrolled down. And I thank the American Migraine Foundation who posted some links regarding pediatric migraine. And if you're interested in more information regarding this, we can always do another post at some point in time about these kinds of topics. I appreciate your time, and good luck with all of your cases and your babies and your friends' kids and everyone out there. I hope that everybody is healthy and happy and have a wonderful night. Thank you for your time with me.